We shall discuss the refractive errors in three parts. A. The basic optics. B. The clinical presentations. And C. The treatment. In today's presentation, we will discuss the optics related to refractive errors. The light rays entering the eye converge due to refraction at various interfaces: air and anterior surface of cornea, posterior surface of cornea and aqueous, aqueous and anterior surface of lens, posterior surface of lens and vitreous. The converging power of the first two combined, that is the cornea, is about 40 diopters, and the latter two, that is the lens, is about 20 diopters. The cornea and lens combined have a power of approximately plus 60 diopters. In emetropia, or normal state of refraction of the eye, a parallel bundle of rays that enters the cornea with accommodation at rest gets focused on the retina. In ametropia, or abnormal state of refraction, a parallel bundle of rays that enter the eye with accommodation at rest get focused either in front of the retina, that is myopia, or behind the retina, that is hypermetropia. There may be another situation when the rays falling on different meridian get focused on different planes. Example, you see here, the rays falling in the vertical meridian are getting focused in a plane behind the retina, and the rays falling on the horizontal meridian are getting focused on a different plane. Now this situation is called astigmatism. So these are the definitions of emetropia and ametropia. Remember, a parallel bundle of rays and accommodation at rest are important parts of these definitions. For by use or relaxation of accommodation, even an eye with some amount of error can change the plane of focus of the rays. Many of you might be wondering that in these definitions of emetropia and ametropia, I have missed out parallel rays coming from far distance. Most of the students and many of the textbooks in their definitions mention parallel rays coming from far distance. Now, I wish to clarify that in these definitions, what is important is parallel rays. Where they are coming from does not matter, for we all know that rays coming from a far distance are parallel, but we must remember that rays coming from a near light source can be made parallel before entering the eye by a appropriate convex lens placed at a suitable distance. That means such that the light source is at its focal length. We have already talked about myopia, hypermetropia and astigmatism. Now, the refraction in two eyes may be unequal, and this is called anisometropia. When one eye is myopic and the other hypermetropic, as shown in figure 4, it is called antimetropia. This figure illustrates antimetropia. The left eye is hypermetropic and the right eye is myopic. Let us try to think why ametropia happens. Etiologically, ametropia may be there because of a change in the axial length, because of change in the curvature of the refracting surfaces, because of change in refractive index, or because of change in lens position. And depending upon the etiology, we have the terms axial ametropia, curvature ametropia, index ametropia, and positional ametropia. Etiologically, ametropia may be one or more of the following types as illustrated in figure 5. In axial ametropia, length of the globe is long in myopia and short in hypermetropia. In curvature ametropia, the curvature of the refractive surfaces, usually the cornea, sometimes the lens, is more curved in myopia and less curved in hypermetropia. In index ametropia, the lens has a high refractive index in myopia and low in hypermetropia. And in positional ametropia, there is displacement of lens anteriorly in myopia and posteriorly in hypermetropia. Having understood the path of rays in various refractive states of the eye, let us see the role of accommodation, the far point and near point. Far point or punctum remotum is a point farthest from the eye from where an object is clearly focused on retina with accommodation at rest. It is infinity for emetrope. It is a virtual point behind the retina in hypermetropia. So with accommodation at rest, an hypermetrope can focus rays which are slightly convergent on the eye. And for a myope, the punctum remotum is in front of the eye, and this distance depending upon the degree of refractive error. So, an hypermetrope is far-sighted and has to accommodate even for distance. A myope is short-sighted. He cannot see without relaxing accommodation or an external aid for distance. Now, when the person accommodates, then he can see near objects clearly. And near point or punctum proximum is the nearest point at which small objects can be seen clearly. It recedes further as the power to accommodate declines with age. At the age of 10 years, near point is about 7 centimeters, and at the age of 40 years, it is about 25 centimeters from the eye. Accommodation has a range and an amplitude. Range of accommodation is the distance between the near point and far point. And amplitude of accommodation is the dioptric difference between the far point and near point. So A is equal to 1 upon near point minus 1 upon far point. In emetropia, we know that the far point is at infinity. This table shows us the estimates of near point and amplitude of accommodation at different ages. Here we see that the near point goes on receding further and the amplitude of accommodation goes on decreasing as the age advances. Accommodation or accommodative effort varies as per the different need in different refractive states. To focus the parallel light F at the desired plane D, an emetrope requires no accommodation. A myope has to relax accommodation to shift the focus from M to D, and a hypermetrope has to use excess accommodation to shift the focus from plane H to plane D. To focus divergent beam coming from near, they have to use accommodation in addition to that required for distance. A hypermetrope, therefore, has to use excessive accommodation, and a myope has to use lesser accommodation or may even have to relax it. So we see here in this table that where an emetrope requires no accommodation for distance, a hypermetrope requires more accommodation for distance, and a myope requires lesser accommodation or has to relax his accommodation to try to see clearly. For intermediate distance of 100 centimeters and for near working distance of 33 centimeters, they require an addition of +1 and +3 diopters of accommodation. So a hypermetrope would require a +5 or +9 of accommodation, where an emmetrope requires +3, and a myope would require a +1 of accommodation, or may even have to relax his accommodation. You all must have seen that people wearing thick glasses often prefer to remove their glasses and bring the object of near work very close to the face. So this is what they do in order when they are unable to relax their accommodation to the desired level. Accommodation in astigmatism is a bit tricky. A patient is unable to use his accommodation differentially for different meridians. So, irrespective of whether he uses excessive accommodation or he uses lesser accommodation, he is unable to get the rays from two different meridians get to focus at the same plane. And the image is therefore either vertically distorted or horizontally distorted, depending upon which meridian is closer to the focus. Now there is a plane where both the meridians are equally distorted or away from the focus, and this is called the circle of least diffusion, and the patient prefers to see a blurred image rather than a distorted image, and therefore he uses or relaxes his accommodation so as to get this plane of circle of least diffusion to get focused on the retina. We have seen that accommodation plays an important role in refraction. We also know that as opposed to relaxing accommodation, which is a passive phenomenon, using accommodation is an active phenomenon, and therefore it has a lot more range. And depending upon the ciliary tone and the accommodation, the hypermetropia therefore has some components which are illustrated in figures 9a and 9b. There is a latent component that is controlled by the ciliary tone, and there is a manifest component which is not controlled by the ciliary tone. Part of the manifest component is controlled by the accommodation, this is the facultative component, and part remains uncontrolled even after the accommodative effort, that is the absolute component. Here we see that part of the total hypermetropia is controlled by the ciliary tone, and this is the latent hypermetropia. The part which is not controlled by the ciliary tone is the manifest hypermetropia. Part of this is controlled by the accommodation effort, and this is the facultative hypermetropia, and that which is not controlled by the accommodation effort is the absolute hypermetropia. The accommodation effort depends upon the degree of error, the ability. We also know that it goes on declining with age, and the patient's desire. This is the same concept illustrated pictorially. So this is the total hypermetropia, out of which part is controlled by the ciliary tone, that is the latent component. Part is controlled by accommodation, that is the facultative component, and part of it remains uncontrolled, that is the absolute component. Now, as the accommodation goes on decreasing with age, the absolute component goes on increasing and the facultative component goes on decreasing. So the requirement for glasses, hypermetropic glasses, becomes more and more as the age advances. Now with this we come to the end of the discussion about the basic optics of refraction and refractive errors. You may further clarify and test your understanding by attempting the attached MCQs. And in our next presentation, we will discuss about the clinical presentations of refractive error and then the treatment of refractive errors.